progressive vomiting, abdominal distension, and obstipation. Foxy Falcon is an ex-semi-pro skater who's presenting to the emergency department with crampy diffuse abdominal pain associated with pretty severe nausea, and she started throwing up this morning. Every time she throws up, she feels a bit better, but the vomit is nasty and bitter and green. But what's most distressing to her is that she hasn't pooped or farted for the past 2 days. She's like freaking out about it, dude. She has a history of total abdominal hysterectomy, which was for uterine fibroids. On exam, there's no evidence of peritonitis, but her abdomen is pretty distended and is mildly tender. On labs, she has a mild metabolic alkalosis going on, but nothing really else is wrong. We were asked 2 questions for this case. First, what is the most appropriate first steps for imaging? And then, what are the most appropriate best next steps?
Oh, bro. This skate park is totally tubular, dude. Oh, wait, is that a rock slide in the pipe? Bro, the pipe's totally blocked. Nothing's getting through. Kinda like our clinical case. And this poor little bro dude here, he's totally wiped out, bro. Dude.
I wonder what could be up with them. So, for our clinical case, she's not pooping or farting. So nothing seems to be getting through Foxy's gut, huh? And based on all that vomiting, it seems like things are backing up into her stomach. That's just grody, bro. So could something be blocking the bowel or, obstructing it? I wonder what sort of things could do that to someone's belly. Let's start this skate park sketch by talking about causes. The small bowel is the most common site of intestinal obstruction in the GI tract, due primarily to its relatively small lumen. It can be either mechanical or functional in nature. Mechanical meaning something is physically blocking the path, and functional meaning abnormalities in the physiologic functioning of the small bowel. We'll start with mechanical, which may be due to extrinsic compression, intraluminal obstruction, or intramural pathologies.
Time to drop in.
The most common cause of small bowel obstruction is mechanical constriction of the bowel by adhesions, which are abnormal fibrous bands just latching onto the side of the bowel. Like this guy grabbing his buddy's shirt so he doesn't fall. The small bowel can get all caught up and twisted on these, causing external mechanical constriction. Adhesions develop in response to surgery or inflammation in the peritoneal cavity. The most common cause of adhesions is prior abdominal or pelvic surgery, with 80% of patients with SBO from adhesions reporting a history of intra-abdominal surgery. The classic history for these patients is intra-abdominal surgery, even if the surgery was many years in the past. We're talking any intra-abdominal surgery, but especially colorectal surgery, appendectomy, gynecologic surgery, or cancer resection. Want me to say it again? Intra-abdominal surgery.
Whoa! It's like they knew what our clinical case was. Trippy, man. Remember that Foxy had abdominal surgery? Whoa, bro.
In fact, hysterectomies are commonly the only surgery someone will have when presenting with an SBO. But I bet there's other causes of SBO too. Let's keep going. Although the 3 most common causes of adhesions are surgery, more surgery, and even more surgery, adhesions can develop in patients without a history of intra-abdominal or pelvic surgery. Even without a history of surgery, adhesions remain a common cause of SBO. Other causes of adhesions include a history of peritonitis, malignancy, endometriosis, or even inflammatory bowel disease. Infection from diverticulitis, appendicitis, or intra-abdominal abscess may also cause adhesions. Patients who report a history of intermittent obstructive symptoms that resolve on their own and then sometimes recur are more likely to have adhesive disease as the cause of their obstruction. Kinda like those parking spot signs with intermittent times when parking is or isn't allowed, so that you never know when you're gonna end up with a parking ticket.
Dang, bro. I was only running in for a second and it's $170. That could buy so much weed, bro.
This is in comparison to partial chronic small bowel obstructions, but we'll talk symptoms in a little bit. We didn't really get into this history in our clinical case, but if pressed, Foxy may have reported a history of similar mild episodes that lasted a day or 2 and resolved on their own. Tumors are the second most common cause of obstruction after adhesions, in about 20% of cases. This can be from a primary small bowel tumor or from peritoneal spread of malignancy. Primary tumors are more rare and include carcinoid, small bowel carcinoma, and lymphomas. These tumors resulting in obstruction are predominantly metastatic disease, which can either be from peritoneal implants from colonic, ovarian, pancreatic, or gastric cancers, or intramural in the wall from melanoma, lung or breast cancers, or sarcoma. The bottom line here, however, is that if a patient presents with a small bowel obstruction without a history of surgery or other common risk factors, you must suspect that they have a tumor until proven otherwise. Next to our intermittent parking sign is also a kid trying to bulge his way through the gap in the fence, reminding us that hernias can also cause small bowel obstruction. In fact, they're the third most common cause of an SBO. When the hernias are reducible, they can cause intermittent obstruction that resolve when the hernias reduce. But when the hernias are no longer reducible, meaning they're incarcerated hernias, they can cause acute small bowel obstruction. Incarcerated hernias are the leading cause of complications of bowel obstruction, by which I mean ischemia, necrosis, and bowel perforation. A special kind of hernia, called an internal hernia, may also result in small bowel obstruction. These are holes in the mesentery, which can be acquired or congenital, which small bowel can slide into and then become obstructed. Acquired internal hernias are most often due to surgery, where an opening is made in the mesentery, typically in a Rowaney procedure, such as during gastric bypass or a Whipple procedure. Ileal conduit procedures may also lead to internal hernia. Intramural hematomas, similar to this large red backpack, in the wall of the small bowel, usually result from blunt abdominal trauma and may also cause small bowel obstruction. Either early after trauma, the hematoma may bulge into the lumen, or late after trauma, fibrosis of the hematoma may result in gradual stricturing of the lumen. This is most common in the duodenum because it's in a fixed location and may be compressed against the spine during the trauma.
Whoa, dude! Check out this kid's board, dude! Doesn't it remind you of a strictured lumen of the small bowel? And that light looks super radical. I'm talking like radiation.
Other causes of stricture formation, and therefore narrowing of the lumen of the small bowel, may also result in small bowel obstruction. These include Crohn's disease, certain medications such as NSAIDs or potassium chloride, sites of prior anastomoses, radiation therapy, and mesenteric ischemia. Stricture will typically result in chronic symptoms, such as chronic partial obstruction. Volvulus of the small bowel may also cause obstruction, where the small bowel twists itself around a fixed point, like this twisted-up hunk of rebar. To learn about large bowel volvulus, check out our mountain climbing sketch covering volvulus and Ogilvie syndrome. In the small bowel, volvulus typically occurs due to abdominal surgery or procedure that has changed the intestinal anatomy, or due to tumors. Volvulus results in acute small bowel obstruction and often what is called a closed-loop obstruction. We'll get to that later, but remember the term. It means bad news.
Whoa, sick camera, dude! It's like telescoping.
That reminds me of intussusception, where small bowel telescopes into itself. And guess what? That can cause obstruction too. It's typically seen in pediatric patients, but we'll save that for the sketchy peds course. In adults, it can be due to diverticula, like a Meckel's diverticulum, from surgery with intestinal anastomoses, or from tumors. Finally, did you know you can get gallstones stuck in your intestine? It slips out when the fistula is made between the gallbladder and the small intestine. The stone tumbles through the intestines, causing intermittent recurrent obstructions, then lodges somewhere, like the ileocecal valve, and causes complete acute obstruction. Check out our cholecystitis video for more on this topic. All right, well, we have a pretty good reason for Foxy from our clinical case to have an obstruction. Let's look at the clinical presentation next and see if this is actually what she has.
Oh, this dude's about to vom, guys. What's your chucks?
Symptoms of small bowel obstructions typically include nausea with emesis, which can be either bilious or feculent, cramping or colicky abdominal pain, and constipation progressing to obstipation, which means the inability to pass any flatus or stool. Be sure to ask when the last time they pooped and farted was.
Bro! Foxy Falcon from our clinical case definitely seems to have these. She's blowing all kinds of chunks and nothing's coming out the other end. Oh.
These symptoms are variable depending on where the obstruction is and whether it's a partial obstruction, which results in milder symptoms, versus a complete obstruction where the symptoms are much more severe. The character of pain may also help describe what's going on. Mild, vague, and crampy is typically early in the disease. If pain is more constant and more focal, this may indicate peritoneal irritation and development of ischemia or bowel wall necrosis. And finally, sudden onset severe constant pain may indicate perforation. Next, we'll talk about the physical exam. Remember what the findings were in our clinical case? I'll bet they'll come up here. Abdominal distension may be marked, and you may be able to see this from the door. Yep, just as I thought. This sounds just like our clinical case from the beginning. This is more common in distal obstructions, where the bowel proximal to the obstruction fills up with accumulating fluid and air. Typically, distension is much less in proximal obstructions, but nausea and emesis will be more severe.
Oh, yeah, beat those drums, girl.
Along with the distension, there's often the sound of high-pitched bongo drums, called tympany, when the abdomen is percussed. This gives us the classic physical exam description, tympany to percussion. Dullness to percussion indicates fluid-filled areas. If there's acute pain with percussion, this suggests peritonitis and possible bowel perforation. You should also look for surgical scars and palpate for abdominal wall hernias. Surgical scars on the abdomen alert you to likely adhesive disease, and hernias may be the cause of the obstruction or may be uninvolved in the obstruction but just prominent due to the abdominal distension.
The clinical case didn't mention it, but I'll bet Foxy has a gnarly scar from surgery.
On auscultation of the abdomen, you may hear hyperactive bowel sounds, which are like tinkling sounds like stones falling in a metal pipe, with longer, intermittent silent times. The tinkling noise is from air bubbles within the lumen bouncing around as the bowel attempts peristalsis. As the obstruction process continues, the bowel stops attempting to peristalse and bowel sounds become hypoactive.
Careful there, dude. That's my tailpipe.
Digital rectal exam may reveal fecal impaction or rectal mass that may be the source of obstruction. Typically, this would present as a large bowel obstruction, but may sometimes be difficult to distinguish on clinical exam alone. Blood on digital rectal exam, either occult or frank hematochezia, may indicate an intestinal tumor, inflammatory condition, presence of bowel ischemia, or intussusception. As obstruction continues, metabolic alkalosis results, and labs are an important diagnostic test to get early in these patients. The bowel wall becomes edematous, pulling fluid out of the lumen of the bowel. This is called third spacing. With all that fluid clogging up the cells in interstitial space, the bowel wall loses its absorptive function. This, plus continued vomiting, results in an overall dehydrated state. Contraction alkalosis occurs due to activation of the renin-angiotensin-aldosterone system. Remember that with loss of hydrogen and chloride ions during emesis, the body becomes alkalotic as well.
Oh, so that explains what's up with Foxy's labs from her clinical case. Righteous, bro.
This metabolic alkalosis will typically increase the renal excretion of potassium in order to salvage hydrogen ions to counteract the loss of gastric acid. Increased serum aldosterone from the RAS activation will also contribute to potassium losses. Another important consideration is the location of the obstruction. The symptoms may give some clues. Distension, obstipation, and hyperactive bowel sounds typically suggest a blockage in the mid or distal small bowel. On the other hand, if a small bowel obstruction is more proximal, like in the duodenum or proximal jejunum, there will typically be less distension and less change in bowel habits, but more vomiting and a shorter time course from when symptoms started to presentation. In this case, intestinal contents just don't move as far, and they have less room to back up and cause distension. But when they do back up, there's a